to large gallery, which I've managed to do. Okay, so thank you very much. Welcome to this October meeting of the George Eliot Board. As you can see, I'm not Russell. I am chairing on behalf of Russell today, and Catherine Free is actually taking Glenn's role this afternoon as Managing Director of George Eliot Hospital. Just to remind people, this is a meeting in public, not a public meeting. There will be opportunities to ask questions at the end of the agenda. I am going to apologise because I think a couple of us have got a few IT issues. I can't access my papers very easily just at the moment, but I hope that shouldn't make any difference. But if you could just bear with us. Apologies therefore received from Russell Hardy, Glenn Burley and Mark Hetherington, one of our non-execs as well. So you join us after a morning in workshop form as a board, and we've talked about in depth our raising concerns and inclusion culture priorities, and agreed a number of actions that are going to be taken through our people board, particularly around improvement methodology associated with our RES and WDES information. We have also emphasised the importance of freedom to speak up training, which we would stress to all of our staff, because it will make the biggest difference, we believe, around the culture, improving the culture of our organisation. It is really important that people feel secure and safe to speak up. We also had a very in-depth discussion around our financial position, which is very challenged at the moment, like many other trusts and throughout the system and the rest of the country. We talked in detail about the initiatives that are in place and being monitored on a weekly basis and through our directorates to try and achieve a break-even position, which was agreed in the planning round. And finally, we heard a story from an individual who did not have the best of experiences around her mother's death within our hospital. Her end of life experience was not what we would have wanted, and we heard the story around that and have agreed a number of improvements in particular, which again are going to be monitored through our quality committee, but would like to thank those involved that really spoke openly about that experience and our staff's response to what was heard. So a very big thank you there. Presenters, as we go through, there's a lot on the agenda. It's often the case as we get to the end of the agenda that we get to the annual reports. There is not a lot of time allocated to those, but it is important that we do have sufficient discussion to acknowledge the work that goes on there. So please, when you're presenting, assume read so that we have enough time to actually talk and ask questions and have some discussions. We're quorate. Can I ask if there are any new declarations of interest or anything that's relevant to this particular meeting? I don't think so. Thanks very much. And the minutes of the meeting held on the 5th of September, are we happy they reflect a true record of our discussion? Okay, thank you. So I can't actually access the actions here at the moment, but I think from my notes, we can see that Super Saturday Clinics and Super Joint Week, we've been talking about quite a lot this morning as part of our ongoing activities. Maternity overdue incidents have been added to the report this time. We're taking time, and it's important that we note this, to reflect and review and wait for any further guidance that comes out from the Lucy Letby verdict. And we're going to bring back a report on maternity governance processes. Work is in progress with Worcester regarding menu co-production, and our sustainability reporting has been improved, and we're looking at how that's included within the BAF risk. So are we happy that that reflects a true position on the actions? Yes, great. Then I think So over to you, Catherine.
Thank you very much, Julie. So if I just take you briefly through Glenn's report, I'm not going to go through it all in detail. Glenn draws our attention to start off with to the work around elective recovery, and draws our attention to the fact that we often think about people waiting on a waiting list as being those waiting for operations that require admission to hospital. Actually, the vast majority of patients waiting are waiting for outpatient appointments. And he references the work that we are doing with the GEH team, which stands for Getting It Right First Time, looking at best practice about how we make the best use of our outpatient appointments, how we reduce follow-ups that aren't required, and then release that capacity to see more patients who need their first outpatient appointment with a specialist. He also talks about how we can discharge people or give patients control over their follow-up in terms of patient-initiated follow-up rather than us bringing people back at regular intervals. And finally, in this section, he talks about the use of technology. So we know that seeing people face-to-face can be helpful for some groups of patients, but for many other people who are either working or have different experiences, find it difficult to come up to the hospital, there is an opportunity to make use of virtual technology. So one size does not fit all, but that is an area that we should be continuing to explore because it can work in the benefit of patients and create more flexibility for them, as well as maximising our opportunity to see as many people as possible. Glenn then talks about the Integration Front Runner project. This is a Warwickshire-wide project that's being led by SWIFT and in collaboration with the Integrated Care System. And this is working with partners in the domiciliary care market in order to make sure that we can get patients home when they no longer need to stay in hospital. And you can see from the data that is in the papers that there's been a real improvement in the average number of days required to source care for patients at home. So that's really important, particularly as we go into the winter period, and we'll be continuing to monitor that. His report then moves on to the state of the national NHS finances. And he writes that in the across all of the ICSs nationally, in the 4 months to August, there were the reported position was £800 million worse than planned. And what he's highlighting there is that the overspending against the plan is significantly worse at this point in the year than at any comparable figure in the past decade. I think we recognise that we're in a challenging landscape with the impact of strikes, inflation and other pressures, along with rising healthcare costs. So it's not surprising that we, along with many other people, in fact most, are finding it difficult to stick to the plan that was set out. He makes reference to the fact that NHSE has allocated some money for trusts, because the one thing that's changed since those plans were written is the impact of industrial action, but how that's been allocated is not clear yet. And Glenn states his view that it's important that those trusts, like ourselves, that have made real efforts to try and maintain as much activity as possible during periods of industrial action, are not financially penalised in terms of how that money is divvied out, but we'll wait to see how that comes about. We're also going to draw your attention to Staff Appreciation Week. In the week between the 18th and 23rd of September, we marked our 3rd Staff Appreciation Week with the hashtag #YouMatter, so you may have seen tweets about it. But thank you to the charity that supported us. We were able to visit 60 different areas, not just wards. We went to the linen room, we went to the post room. We were out and about all over the organisation, and it was great to welcome the non-executive members of the board in during that week to come and say thank you to staff in person. And there are some photos of some of the people we met on our trip round the hospital, but that was a brilliant thing to be part of. Urgent and emergency care and radiology give us an insight into their work. As you know, the emergency department was rated good in the CQC inspection earlier in the year and was commended in the patient satisfaction survey for having very high levels of satisfaction. Obviously, the emergency department has had a busy summer and continues to have a busy autumn. And the work in that team is around supporting timely discharges from the ambulance service. They also talk about the improvements they've made to the physical estate in order to support patients with mental health needs, such as creating sky inside ceilings, putting some television screens in, making sure that spaces are comfortable for people who need different support whilst they are in our care. And then moving on to the Warwickshire North Place Delivery team, you will see a number of familiar faces there and a snapshot of the people that are involved in that team. Now is a really interesting time for the Place team at Warwickshire North as we start to see the transition from some of the services that were commissioned by the ICB, moving more to how we now deliver care in a joined up, integrated way for our local communities. And there are a number of examples listed in the paper about some of the work that is going on there and about the priorities for Warwickshire North. So hang on a moment, let me see. I think that the only thing left to say on that is that you will see at the end of this tome is all of the places that were visited by a member of the executive team or the board during September, and you see that list runs to several pages because of the work over Staff Appreciation Week, but that's the ongoing work that we do to get out and about. Thanks, Julie.
Thanks very much, Catherine. Thank you. Questions or comments to Catherine or to Glenn through Catherine? Oh, look, Catherine, you've got away with no questions at this point.
I think Sarah's got a hand up.
Oh, Sarah, there she is. Yeah, Sarah, over to you.
Thanks. It's a quick question and comment really on the TOFU and the PIFU, the discharges, and I think really just to commend that wider thinking, but also to acknowledge here that the well-written book of years ago, The Doctor as the Drug, and the fact that actually sometimes the human interaction and the social side of medicine is a valid part of medicine as well. And I think within that, we cannot waste precious resources where they're not needed. However, I think we do need to acknowledge that there will be some need for some of the patients that are discharged to access care and support in different ways. And that may be most appropriately their general practitioner. But again, when the solution isn't a medical one, we do need to think with our Warwickshire North partners as to how we best help people to stay well outside the confines of the hospital and potentially even outside the confines of what we'd call traditional medical practice. So I just wanted to make that comment, but say that I think the piece of work is really positive. So thank you.
Thanks, Sarah. I think that's a really important point. So thanks, Catherine. I think the report sets out a number of initiatives which improve patient experience, waiting lists, and the financial position as a consequence of that. But it's really important to acknowledge the work of our staff, those that are in the report, but also everybody else who's working through times of continued levels of pressure. So thank you. With that, we'll go on to Warwickshire North Winter Plan, which I think is you, Robin.
Yeah, that's right. Thank you, Chair. The first thing I'd say really on this is the backdrop to winter this year. We know that some people would say, have we ever emerged from winter from last year? It feels like that to a lot of our teams, and I think we need to acknowledge that continued pressure first of all. But obviously, there's challenges of the unknown ahead of us again, as always, for winter. And with that may well be resurgence of flu numbers, may well be COVID, it may well be norovirus, it may well be other respiratory disease challenges ahead of us, or just the overarching increase in activity across winter that historically we've seen within the NHS. So this paper is an annual paper that we bring forward to look at how we're going to address those challenges. The more eagle-eyed of people who read this will notice that the first thing to change on this year's paper is the title. So this is a Warwickshire North winter plan. This isn't, historically we would have brought forward the George Eliot Acute Hospital Trust winter plan. This is about a place. This is about Warwickshire North Place, and that gives an indication as to the way this has been generated. So this has been generated by the discussions that started in May this year, based on what did we do well last year, what did we do that didn't work so well, and taking that learning from all of the system partners across Place, who've generated a plan together. So other system partners will be taking the same detail to their boards for their own governance process, but they all align into one Place plan. The feedback also from system partners also incorporated patient feedback as well from various patient forum groups across the system. So we really have got delved far and wide to try and understand what actually worked well. So the key areas of focus then, to summarise, there were admission avoidance, and particularly around frailty and respiratory focus and services in the community, and how best they can be developed to keep patients at home as long as possible. Improving hospital flows and therefore trying to reduce length of stay, so reducing that exposure to patients for hospital-acquired infections and the deconditioning that takes place as patients stay in hospital for longer than they absolutely need to for their acute care. Also noting the progress with the 2 new wards that are being built on site as we speak. And also the site reconfiguration work that needs to take place in order to get ourselves as an acute trust into the absolutely optimal setup in order to use that space to its best advantage. The paper also makes reference to the financial funding flow. So you can see that there's just over £1 million that's been allocated from across the system to Warwickshire North. There's also further monies that are coming through that were effectively top sliced that are going out to support further community services, of which Warwickshire North will be included, and they're alluded to in the paper. The risks, we don't know when winter will start or end. It's, as I say, for some it feels like it never ended from last year. There's a risk around, we know that successful delivery of social care schemes are always a risk to us, but they have started early this year, and they've started with the community recovery services and bolstering the staffing requirements for those. And also we know that there's a risk around the 2 new wards, and obviously with any building project we know there are risks associated to potential delays, but at this point in time we remain on track. Unknown impact of flu and COVID, of course, again, likewise with the other disease I've mentioned, or the other infections, there is potential resurgence of any one of those that could cause us infection control challenges, shall I say. And the final one I'd mention is staff availability. You know, we know that workforce often causes a key talking point in the workforce plan. And this year, rather than looking at how many staff we're going to recruit for winter, recruitment is continual for most of our specialties and most of our system partners. The areas of focus this year very much are on how do we support the staff that we've got, how do we look after their well-being, how do we retain the staff that we've got, and also how do we reduce sickness of the staff we've got, recognising all of those challenges for our teams, and as I said, repeat some of which feel as though winter never ended from last year. So it is that is going to be a significant workforce challenge for us, but one which we're aware of and one which we will pay particular attention to. There is also a winter project team at place level that's already been put in place in order to monitor the action delivery and the impact, which will not only inform any changes that need to happen in real time in this year's winter plan, but will also serve to be the starting point for next year's winter plan. And I'll end there, Chair, and happy to take questions.
Thanks very much, Robin. Questions for Robin? Obviously a very well written report, Robin. I have got a couple, if that's okay. So for me, this is what I really like is this is a Warwickshire North plan that's been put together. So the importance of place is really important. My question is how that goes into the wider system planning for winter. Part of the ICB's approach to winter planning. That's my first question. My second question is around, and forgive me if I'm not reading this and I can't just access the report at the moment, but the risks that we allude to, if industrial action continues, is that clearly been thought through as part of the winter plan? So how it feeds into the wider system planning piece and the impact of continued industrial action.
Okay, thank you, Chair. So if I take your first point around the wide, how does it integrate into the wider system plan? The ICB have been coordinating the funds came down centrally from NHS England quite early on. So that sat with the ICB, and what they've gone through is a process that split out the 4 places. So they have had regular meetings with the leadership teams from each of the 4 places across Coventry and Warwickshire. So that would be Warwickshire North, South Warwickshire, Coventry and Rugby. And we have each of us got very clear allocation on their plan for specific schemes. And those have been worked through in each of those places in the same way as we have in Warwickshire North. And as I mentioned about some of the community-based services, so for example, the community-based respiratory services that were put in place last year, those are being centrally funded out of that pot because it's recognised that those need to take place in all of the places. So there are some commonalities between some of the place schemes which are being funded centrally, and there are some then specific place-based schemes as I've detailed in this paper. So that's how that all fits into the system approach. And I have regular meetings with Becky Hale, who's one of the chief officers at the ICB, who's leading on this. I met with Becky this morning, for example, at 8 o'clock, in order to get the latest update on where they're at in terms of those allocations and keeping track of the conversations. So that's how we play into the ICB and wider system plans. In terms of the risks around industrial action, that's a really difficult one for obvious reasons. Obviously, we don't know what lies ahead of us in terms of industrial action dates, in terms of the way in which those will be aligned to whether that's specific to either, for example, on our BMA colleagues, whether that's specific to junior doctors or to consultants or combined with both. And a lot of permutations there as to the services that we can and can't run during those periods. So as we work that through, the winter plan is predicated on us having our full staffing complement. But there is obviously an inherent risk there around industrial action impacts that we will need to manage as we get the notice for each of those periods in the same way as we do at this point, but for our normal services.
Thanks very much for that, Robin. Jackie.
Thank you, Chair. It's a very informative report, and as Robin has said, I'm pleased to see that it's actually a Warwickshire North plan and details how we're going to support the system over the winter. I wanted to ask about mental health, because I know currently there are blockages in several trusts with regard to mental health patients in regard to their flow, and I just wondered how that's picked up through the plan.
Yeah, in the same way as I mentioned about the community respiratory clinics as an example, mental health is another one of those examples of where there is a system-wide approach and funding. So the monies that come down from NHS England, there's a slice of that money that has automatically been top-sliced out to support mental health services. And those are conversations with CWPT, who provide and coordinate those services across the system in order to ensure that they've got a robust mental health winter plan that will align to the work that we're doing here. So it's a part of the system-wide approach.
Thank you. Thanks, Robin. So I think everybody would agree it's a really good plan. We're asked to approve this plan. And unless anybody says to the contrary, I think you're getting great support for the fact it's been developed at the level of place, fully integrated within the way that the system's working, applying learning from 22-23 in a realistic view of the risks associated with delivering it. I think the funding is also clear around this. So with that, I think we're happy to approve the plan. Thank you.
Thank you.
Sustainability report to receive a note. Jenny, over to you.
Yeah, thank you very much. And as I say, we'll as soon as the paper is read, I think Sean is also in the gallery. Just to note that obviously he's one of the key people that's been supporting us with this work. Just a couple of things to note, just in the spirit of being the Appreciation Week, wanting to specifically note the work of the Sustainability Champions, and that's detailed in the report. And it was great to see a number of those Sustainability Champions when we reached out and went on our walkabouts as execs, and they're so enthusiastic. So really want to just highlight that. You can also see that we've got some integrated work with the charity. So just to say that we're linking in around sort of the bids as well for sustainability with the charity, which I think is something to note. The SALEX bid, which is the public sector decarbonisation scheme, is a separate paper, so I won't draw attention to that because we'll be discussing that later. And the appendix details a number of examples of deliverables in each of the 9 focus areas, which gives assurance that we continue to make progress in all of those areas towards our decarbonisation plan and our green plan. I will not give any more further detail because we'll assume it's read, but I hope that gives you a flavour of some of the activity and assurance of the progress that is being made in this agenda.
Thanks very much, Jenny. Questions or comments to Jenny? Rosie.
Thanks, Jenny. It's just a question. I've been looking at the Centre for Sustainable Healthcare website quite a lot recently. And I'm just wondering if you are also using it. It's got some fantastic resources and stories of QI projects. Just thinking of the champions. I was just wondering if you'd seen it.
Yeah, thank you. And we're also plugged into the Futures platform as well, which is another resource where there's a lot of really exciting work going on and sharing. And we also work across the foundation group, so plug into all of those different routes. And as you say, there's a lot of innovation going on and some good practice that can be shared. We also ensure that when we meet with our focus leads, which is twice a year, that we're supporting them with some of those connections. And we also have, I think it's detailed in the report, updated the website area specifically on sustainability to create some of these links as well. So, but thank you for that, and we'll certainly make sure that we're plugging into all those resources.
Thanks very much, Rosie. Any other questions for Jenny? No, thank you. I think we can really take some great assurance from your report, Jenny. Significant activity. It's good to see the passion and the embedded governance as well. So thank you very much. We're moving into the quality section of our agenda. We start with Natalie around safer staffing for nursing and midwifery.
Thank you, Chair. I'll like to highlight 3 areas within the report for this month. As we're all aware, the report focuses on the safer staffing, but also on any incidents, care or patient-related incidents in accordance with staffing gaps. So our recruitment continues. We have monitored and talked about over the last 6 months our recruitment, and particularly focusing on our retention. Our domestic and international recruitment of registered nurses is beginning to bear fruit, and we're seeing our successes come through and be out on the wards delivering the care to the patients. Also like to recognise the real success in our healthcare support worker recruitment and retention thus far. Attrition rates for healthcare support workers are nationally quite high, and I'm really pleased to say that currently, and not counting any chickens as yet, we haven't seen that. So the work that we've put in to the quality mark and our retention piece, ensuring that the welcome that our healthcare support workers receive and the programmes of development is our focus. So we will continue to monitor that. And as a result, we are seeing a slight decrease in our NHSP shifts for temporary staffing, which again is a focus that we've been looking at. With regards to the safer care of our patients, you'll note from the report that we had 25 staffing data related incidents in August, 9 of which were within midwifery. And I'm pleased to say that all of those are reviewed and looked at as individual cases, and no harm sustained to any patients due to staffing levels. The operational pressures across the organisation, as Robin mentioned previously, with the planning for winter, but actually that winter period, as it's so called, hasn't let up, and all of our extra capacity areas continue to be open, which has caused a pressure with incurring costs, because we are having to use more temporary staffing than we would like to. We've also seen that the sickness has remained at for nursing roundabout and just above 5%, and we're working very hard to be able to reduce these. Talking about the sustained pressures, you'll note in the report that we do monitor and review the safety across all of the shifts every single day, and we have had to redeploy staff to other areas to ensure that safety. We've also looked at the enhanced supervision for those patients that need that enhanced care and the one-to-one supervision, and you'll note the number of times that we've had to increase our shift resources because of that. So the final thing that I wanted to pull out of the report, and it is really a testament to the great work that our retention matron, Sharon Tallis, and Justine Whitmore, our wellbeing lead, are doing on retention. In conjunction with the work across the ICS, we have several retention work streams, and we are focusing on our early career, mid-career and late career nurses, and we have different areas that we're looking at and putting different things into practice. But it's also about the focus on why our leavers are leaving, and we're getting much more information. Those may remember that probably 6 to 8 months ago we had a number of leavers that it was unknown the reason for leaving. That has reduced significantly with the work in conjunction with Gertie and her team, and we are now able to focus the retention work on the areas that we are being told. So in the month of August we had 9 leavers in total, four in registered nursing, 1 maternity, and the remainder in healthcare support workers. And the report highlights the reasons for that so that we can inform the work that we're doing. And to end on a positive, there was a meeting yesterday across the region for our AHPs, and Liz Mathers, our lead in this area, was our representative, and we do have, touching all wood here, the lowest vacancy rate across our AHPs within the region, which again is a real great testament to the work at George Eliot and the development and leadership that are offered to all of our staff in their roles. Happy to take any questions.
Thanks very much, Natalie. Questions for Natalie? Gosh, another really good report. Sets out everything that we need to know, but again, very detailed report, Natalie. It demonstrates the focus and the priority for maintaining safe staffing levels, but it also demonstrates the pressures that we've got and the challenges and the progress though that's been made on recruitment. Catherine and I also met the focus that's been given about retention. We did see them working together there. So I would add that the detail around this is scrutinised by quality committee, and hence why probably there aren't so many questions when we get to board, but the quality committee minutes will reflect the fact that there's much more discussion within that committee. So thank you very much. And I think we're now bringing in Lorraine. Hi.
Good afternoon. Thank you, Chair. So I'm going to take the maternity assurance report as read. I've got some areas I'd like to highlight, and this is data for August 23. So in August, we had 59 Datex incidents reported, and at the time of this report, we only had 15 overdue incidents, which is a real improvement from the last month where there was 45. We had no maternal or neonatal deaths in maternity, and we've got no serious incidents declared within the month of August. We have 25 risks on our risk register now, and all of those are up to date. Our midwife to birth ratio in August was 1 to 28, and all our women received 1-to-1 care in labour. We sadly had one stillbirth in August. This was a lady that was 26 weeks and 4 days, and sadly came in with no fetal heart. Her family and herself and staff have all had bereavement support and care, and obviously we review all our stillbirth cases through our perinatal mortality review tool. While I'm on the talking of stillbirths, obviously our Embrace report for 2021 was published in September, and you probably have seen a lot of media interest. We have provided media reports, and also there was a BBC Midlands News report last night. So we were fully aware that we would be an outlier in 2021. We'd already done a forward outlook during that time of COVID, but to give the board reassurance that we monitor our stillbirth rate really carefully, and our current rate is 1.88 per thousand births, which is way below the national average 4.2 and the Embrace report of 3.6, and our neonatal deaths are also way below the national report. So although we were high in 2021, our rates have come down and have maintained below the national rates. We closely monitor all of our stillbirths and our neonatal deaths through our bi-weekly Maternity Safety Champions production board, and through our governance processes, and obviously all cases get reviewed through the perinatal mortality report. PRMT is the tool that we use. We will have also do a very detailed review of all of our cases from 2021 through our annual mortality review, and we'll bring that back to board in October. Well, it'll go to QAC in October, Quality Assurance Board, and then we'll come to board in due course. But it's just to give reassurance that we monitor that all our cases very closely. We've got no current HSIB cases open, and we did have our maternal death report from HSIB come back. This is a sad case of a lady that passed away in January. They've done a detailed review of that, and we'd already done an action plan and a review, and the report highlighted that all the areas that we identified for learning, had been identified in our action plan, and we will obviously send the duty of candor final letter out to the family. Training figures remain really good from within maternity, and our ongoing work within refurbishment is on plan and looking very good. I suppose the last thing I'd like to highlight is we've been waiting for the CQC for a long time, almost a year, and they did come and visit us on the 13th of September. They are still we're having to provide data for them, but the initial feedback was that they found our staff being very open, honest, and wanting to speak to them, and really identified good MDT working. We hope to have the draft report within about 4 weeks so that we can review that for factual accuracy. Those are the main areas I would like to highlight, and I'm very happy to take questions.
Thanks very much, Lorraine. Questions and comments to Lorraine? Sarah?
I think you've answered this one really already, but I just want to draw it out of you, if that's okay, from a non-exec point of view and from a quality point of view. You've talked about us now and been below the national rate for stillbirths and for neonatal deaths. I'm just interested in the level of confidence you've got that can be sustained going forwards, and that you're not just reporting to us a good level now, but something that projects to worsen again. So your level of confidence in that, please.
Yeah, so we do that on a 12-month rolling review. So we obviously know all our data in real time and can look at those themes and trends across that. So our rolling rate has remained below the national average. So Italy since December anyway. So I'm reassured that we've got a good focus on our data. we know our data and we review that in a timely manner, and we'll be able to know in real time whether we've got an issue with anything raised at the time, rather than waiting 2 years for your report to come out.
Thank you. Thanks, Sarah. Thanks, Lorraine. Paul.
I suppose it's more of an observation than anything that I'm pleased to see that we've been able to maintain midwife to birth ratios even in the face of a sort of average 10% vacancy rate. And I assume that's been achieved. I think I read in here it's been achieved by sustaining the use of agency staff. How confident are we that we'll ultimately achieve our aim of not having to use agency staff in the sort of short to medium term?
Yeah, so our trajectory is, I mean, we're October now, so we've got our newly qualified midwives who will be joining us between now and January, which will take our trajectory down to about 1.8% vacancy rate, which is, when you look at regionally and nationally, that is way below the national average. Staff wanted to come and work here. We are very lucky that we are able to recruit and retain our staff, and we work really hard with our retention team, our retention midwives or PMAs. And we have a workforce matron starting as well soon with us, that it's about retaining our staff and making it a culture that staff want to work in. So really pleasing to see that. We very rarely now use agency, but where we need to, if we've got high levels of sickness or acuity, then we need to. But that has to be approved on a daily basis if that happens, and we should see our bank usage go down as our staff start to come into post, and we need to work on our sickness and make sure we maintain that below. But yeah, really pleasing position to see, and I'm pleased with our trajectory.
Thanks very much. Thanks, Paul. Thanks, Lorraine. Thanks very much for your report, Lorraine. I think it does give us assurance. We do have this separate focus on maternity and the key metrics, which we again interrogate and scrutinise at Quality Committee. So thank you. Thank you very much.
You.
And Catherine, taking the floor again with the Integrated Performance Report.
Thank you, Julie. Well, as it says in the Managing Director's executive summary in the IPR, as expected, August was a difficult month. So let me explain what that translated to. So in August, we saw a dip in a number of performance metrics that included the 4-hour target, where 70% of our patients were seen and discharged from the emergency department within an hour, compared to the national standard of 76%. We saw an increased number of ambulance delays over the hour, and 65 patients waited over an hour with us. And we saw 10 12-hour trolley breaches. That's 12 hours from the decision to admit a patient for us being able to find them a bed on a ward. Usually that is a 0 number for us, so that was exceptional too. And we also saw a fall in the number of elective operations we were able to deliver in month, resulting in a rise of patients waiting over 52 weeks from 158 to 172 patients. And as I set out last month, in August, the usual challenge of high bed occupancy and what is now sadly becoming monthly industrial action was further compounded by the need to close beds on the Captain Tom Moore unit to allow us to construct the 2 wards above, which will give us 60 new beds due to open in January. These bed closures caused additional strain on our available beds, which are already under pressure, and that caused a knock-on effect to all of those metrics. Just to put this in context, the national ED performance in August against the 4-hour standard was 74%, so below the newer, reduced national ambition of 76%. Notwithstanding the challenges on bed occupancy and the ongoing industrial action, our elective position in comparison to many others remains very good. We are maintaining our position of no patients waiting over 78 weeks and are on track to deliver no patients waiting over 65 weeks at the end of the year, which is the national ambition. Our numbers in comparison to regional peers are excellent, And despite seeing a rise in patients waiting over 52 weeks, our recovery actions are focused on specialties that are most impacted on this, including, for example, a plan to undertake 40 joint operations in a week at the end of this month. And as we know, it's often patients waiting for hip and knee replacements that are delayed because their condition is not life-threatening, but we know that leaves patients in pain and suffering from a reduced quality of life. So it's really important that we view this holistically and take care of everybody that needs our care and attention. In terms of cancer, the 62-day performance in cancer improved in July to 61.9%. That is still a long way below the 85% target, but much improved on the previous performance of 47.3%. Work is continuing on our cancer pathways so that we can benefit from the CDC when that opens in spring of next year, and to try and maximise the use of one-stop clinics to value and respect patients' time and try and reach diagnosis faster. The faster diagnosis standard for cancer in July was maintained at 70.4%. And as I explained last month, whilst every effort is made to prioritise cancer care during periods of industrial action, this is something that's difficult to maintain when we are trying to do not only operations, clinic appointments, but also multidisciplinary team meetings that involve a number of senior clinicians, sometimes from external hospitals, and that can cause delays to patients. So it's something we monitor very closely and try and minimise wherever possible. In diagnostics, whilst we're not meeting the national standard of 99%, our performance is 92%. I think we're performing very well in respect to this because the national average for this measurement is 75%. Robin's report outlines the steps that we're taking in order to improve our position further, because we know the importance of patients, not if they're waiting for their diagnostics, that delays other aspects of their care as well. On quality, there's been a further improvement in both the mortality indicators of SHIMI and HSMR, and it's pleasing to see a reduction in the number of hospital-acquired infections reported this month. There's been a lot of focus in that area, and it's good to see that picture improving. As Lorraine has already referenced, the CQC did an inspection of our maternity services as part of the National Programme of Maternity Inspections in September. And whilst we're awaiting the final report, I'm pleased to say that there were no serious findings raised, and our teams were commended on their open culture, their work around addressing health inequalities, and the fact that staff were developed and supported to develop their roles further. And our workforce metrics, appraisal rates have fallen slightly in month. We have been doing a lot of work with the directorate teams, but this is an area that is proving really stubborn for us in order to shift that. What we have seen is our statutory and mandatory rates really improved once we switched over to something called My Learning. And I've asked the teams to accelerate the work around the appraisals and try and moving those to My Learning, so that we can equip managers with the right tools to understand who's due an appraisal, who's overdue an appraisal, and also to reduce the burden of administration that at the moment our system can be a little clunky. And I think that would really help us to ensure that we are making sure that all our staff have a high quality appraisal. I'm not going to go into detail on our financial position because as a board, we spent a long time going through our financial positions and the drivers for this. But it's important to say at month 5, we're reporting a deficit of £4.4 million, which is off plan by £2.4 million year to date. As we've discussed this morning, the majority of this is due to an under-delivery of our cost and productivity plan. Our focus as a board remains on the 3 main priorities for high quality patient care. And in turn, that will help us to manage the financial position. And those are reducing our bed occupancy so that we care for the right person in the right environment, in the right place with privacy and dignity, that we focus on treating those patients that are on our waiting list, whether those are patients waiting for operations or our outpatients, and that we focus on the work around staff availability and recruitment, in order to make sure that we have the right number of appropriately trained staff to care for the patients that need us. All of this has to be underpinned by attention to well-being, and on my trip out at lunchtime I bumped into the team from the emergency department talking about the importance of being able to get rest during busy periods, and we will relentlessly focus on that and our messaging to leaders in our organisation about the importance of allowing people to have the right rest breaks and to finish on time, because we've got a busy winter ahead of us. And finally, this is National Freedom to Speak Up Month. Julie, you've mentioned we spent some time as a board thinking about this, how we create the right conditions, the right culture for staff to feel safe to speak up to us about things that need to be improved. Our staff survey is now open. This is the National NHS Staff Survey, and we're working hard to ensure that as many colleagues as possible get to have their say. We know that we have work to do in the area of speaking up and ensuring that every single one of our staff feels supported and safe at work. This is such an important measure for us, and I encourage any colleagues that are on the call or listening to the call to complete it. And we commit as a board, we will spend time understanding what you've told us and using your feedback to shape our plans for the coming year. Thanks, Julie.
Thanks very much, Catherine. Questions to Catherine? Thank you, Catherine. You did very well to actually really draw out the key things that you wanted us to take note of this afternoon. I think for me, we heard the continued demand, which is also impacted by industrial action. The works around the hospital are going to have a longer term benefit, but we need to note that that's going to cause some initial problems in the short term. We know that the metrics aren't where we want them to be. We've got money challenges, and we've got that real emphasis on theatres and outpatients, and also maintaining patient experience. It was good to hear the initial feedback from CQC following their visit to maternity, and your plea, I'll say it again for you, Catherine, to encourage staff, please, to complete the staff survey. It is really important that you complete that survey so that we can hear what you are saying and we can look at it in detail as a board. So thank you. And I think again, you, Catherine, on the board assurance framework, I think it's you.
It is me, yes. So it's another weighty tome, the board assurance framework. This is our view on the risks around our strategic objectives as a board. Thank you to Claire Hayward for all of the work that goes in putting this together, and to all of colleagues on the call and people that work in our teams in terms of the updates provided. The main areas to note is that the risk around finance, the risk and actions have been updated and triangulated with the corporate risk register. There have been no changes to the level of risk appetite, and you will find that there's cross-references between the risks on the BAF and the risks that Natalie is going to come to next in the paper in the corporate risk register. The BAF has been through the Executive Risk Committee. It has also been discussed at the Quality Assurance Committee at the end of September, and Anil has had it from a finance and performance perspective. So I'm happy to take any questions, or any of the team will take any questions if they're very specific.
Thanks, Catherine. And the BAF, the Board Assurance Framework, is a very robust framework. A lot of work goes into it. So, Paul, question from you.
Yeah, just a question, and only about because of my newness. I assume that from a process point of view, the audit committee look at this, Catherine, so that we're aware, and as an audit committee member, we can be assured that the process itself is robust and working as it should be, rather than looking at the detailed specifics of each individual risk. So I heard you mention pretty much all the committees except audit. So I was just asking that question, I think.
Shall I come in there, Catherine? So,
go on, Julie.
No, Julie.
As ex-chair of audit, and Simon would say the same. So with audit committee, we're very, very involved in the development of the new board assurance framework arrangements, and we have agreed that as part of its annual programme of work that the audit committee will look at the process, as you say, not around the individual risks, and often as well that will be supplemented by internal audit reviews as well. So it is built into the work programme around the time of the close of 1 year and the opening of new risks. Okay, thank you very much. Over to Natalie.
Thank you. And as Catherine mentioned, this does cross-reference with the BAF and in particular any areas of high risk and extreme risk. So this report covers the period of Q2. And for note that we have 23 risks that are deemed either extreme or high on our corporate risk register. 2 of those risks have been there for a period of time, and they are to do with our recruitment and workforce, plus our reducing our bed occupancy. And I think we've heard throughout the board today about those 2 areas in particular. 3 corporate risks were reviewed through the Executive Risk Committee and the other processes, and removed and reduced in their severity. And 3 high risks have increased to the extreme level of 20. And again, you'll note that we have already talked about those areas today when we're talking about industrial action and the financial picture. And the third one that has increased is our EPR project. 4 new risks have been included in this month, and some of those I've already just mentioned. And the one to note that is going to be coming forward to the corporate risk register is the cleaning and audits within the organisation. We previously had a risk that was on the risk register with regards to our vacancies in our domestic staff, and unfortunately those vacancies have increased again. Therefore, we have reviewed that risk and we will be increasing that and putting that back on. That being said, there is already a robust recruitment drive for domestic staff, so we're hoping very much that we'll be able to put it on and then review in a couple of months' time and be able to reduce again. But I'm very happy to take any questions on any of the other areas that are within the report.
Thanks very much, Natalie. Questions to Natalie around the corporate risk register? Paul?
Just one briefly. We talked this morning very briefly about EPR. So given the issues that we're having with MOU and agreeing an MOU with UHCW, sorry about the acronyms, how much is that likely to delay us? Have we got a sense of that? Because obviously an EPR is one important way of delivering better care and better efficiency, etc., etc. So we got a sense. I think Robin's going to jump in.
He is definitely. I was going to.
Robin, over to you.
Robin.
Natalie, unless you want to answer that one, no. No, it's a really good question, Paul. I think that obviously the conversations still continue, and we'll obviously have more discussion later on in the confidential board agenda later, where I'm sure this issue will come up. But in terms of the timescales, obviously it's dependent on the timescales. Any knock-on impact is dependent on the timescales with Cerner for their ability in order to factor in the work stream associated with our deployment. At the moment, the indications from Cerner are that obviously they're still holding our current time slot, but there is an indication if we did have to slip, there is an opportunity for us to slip that for be around about 3 months before Cerner could then get the next time slot in, which would effectively push our go live date to around October, November 2025, obviously with a 12-month lead in time. So it's the slippage of 3 months isn't huge, but again, still material in the grand scheme of things.
Thank you. I think Paul's question as well was the impact on the improvements that we've talked a lot about today. But what I'm hearing there, that the work here on EPR is a much medium-term improvement, not the current year. Yeah, the implementation of the EPR system wouldn't be scheduled until July 2025 anyway. So yeah, in essence, what that will do is will mean that we there needs to be the short medium term solutions in place, whilst we then wait for that longer term advantage that we'll get from a full EPR system. Okay, thank you very much. Thank you for that. Thanks very much, Natalie. We're running way ahead of time, which is really good. Means that we have enough time for the annual reports as well at the end of the agenda. So board effectiveness annual review, Sarah.
Thanks, Julie. So this report just gives an overview of the current state against the board effectiveness annual review that took place, and progress to date against the improvement areas that were identified as part of that review. All areas are complete apart from one, which is around reducing the length of the board meeting book. And today's agenda is actually an example of where we are making improvements, where the annual reports, the full annual report isn't coming to Trust Board, it's a summary, and then the annual report is available either on the intranet, the website, or on request. And that's included in those reports. So happy to take any questions. Thank you.
Thanks, Sarah. It's important to note it was an independent review that took place, that we have completed those. And yeah, it's made a difference to the length of the board pack by actually putting links to those reports rather than having them attached. So thank you. Any questions to Sarah? No, thank you very much.
Thank you.
So we're into our annual report section of this agenda. We've got 3 here, where we've got summary reports attached, but then links to the main reports. First of all, so 2 for you, Natalie, and I think we're expecting Kirsty as well if she's not already here. So Natalie, first of all, summary of voluntary services activity.
Thank you, Chair, and I'm really pleased that we are able to take a little bit of time to recognise the work that our volunteers do across the organisation. And also you'll note in the summary report the link across the community and place as well, and linking that up so that we've got a rounded view. You'll see that our volunteers give of themselves so many hours to both the patients and supporting our patients and the care that we deliver and the experience that they experience, but also fundamentally in releasing our clinical staff and our staff to be able to undertake the work they need to do. The report sets out areas in which we have worked together on what we can do with our volunteers and how they can offer that support. We try to quantify a little bit with regards to the hours and the financial impact, but really and truly it's about the individuals themselves and their giving of themselves to an organisation that, if you ask most of them, they will say that they are committed to and are really love the George Eliot. So they have been helping with reducing the pressure and being able to do timely discharge processes, be able to offer comfort calls and supporting patients post-discharge, to be able to look at our waiting lists, be able to give some calls to patients that are coming in and to ensure that if they are coming in, that's great, but also where they're not able to, we are able to then reduce the DNAs, etc. The freeing up of the staff time, as I mentioned, undertaking some of those tasks on the wards that free up the clinical staff to be with the patient. I can't not mention volunteers without mentioning our emergency department. Our volunteers in the emergency department are have high accolades every time that you go around and you talk to the staff. The staff are really appreciative of the work that they do. But we're not stopping there. There are things that the team want to do. There are developments that they're looking into, particularly in the area of looking at diversity and increasing the diversity within our volunteer team. And that includes also looking at our younger volunteers and leading and increasing the ability to support them going into work, and really supporting the community in that way. We're looking to continue with the calling of those patients. We're reducing do not attends, but also with the pre-op calls, and where we can, how to support patients that are going to be coming in for any operations and procedures. And we're working very closely with the team to be able to do that. So I think the annual report in itself, which is available as mentioned, is a wonderful read, a celebration of those teams that, as I've said, give of themselves to help and to improve the care that we deliver to the patients each and every day, but also as a supportive mechanism to our staff. And I just want to, on behalf of the board, all of the executives and non-executives, say a huge thank you to all of the volunteers that work with us tirelessly every single day.
Thank you very much, Natalie. Thank you. Questions, comments? Jenny?
Yeah, well, just a comment and to echo really what Natalie has said, but just to particularly note the innovation that's been happening within the volunteering sphere with the team, with the Back to Health programme, etc., which has also been a place programme linked in with our primary care networks and our community partners, and particularly linked into health inequalities with trying to recruit from and link assets into perhaps some of our more deprived communities. So it's been a pleasure working with Becky and the team and the volunteers, and yeah, just totally agree with Natalie, but just to draw attention to some of that innovation because it is quite incredible, and there is a potential award in the offering that's subject to, but we'll see what happens there.
Thank you. Keep our fingers crossed. Thanks, Jenny. Rosie?
Just a wonderful report. Thank you for sharing. Really enjoyed reading it. And I put 3 questions in the chat, which I thought was a bit greedy. So maybe I'll just pick up on the first one, depending on time. So I'm just thinking about the winter plan and how the volunteers might be harnessed somehow to support the winter plan. I'm sure you've already thought of this, but I just wondered whether it had been a consideration, and also then linking into staff wellbeing, and are there any other untapped ways that the volunteers could help with staff wellbeing?
Well, they're really good questions, Rosie. So with regards to winter planning and actually every single day, the challenges that we have with operational flow and particularly discharge, they're already doing a huge amount. It doesn't mean that there aren't other areas that we can look at, and I know I can see Robin nodding in the background. We have considered those, and we're continually asking not only our volunteers, our patient forum, which is a separate area that also supports the organisation completely, in what can we do, how do we push those boundaries within the realms of the limitations of volunteering. And with regards to well-being, again, I'll reference back to Justine and her team. We are looking at that, things like being able to give somebody a bit of a break, a cup of tea, being able to support them. So we do have a number of volunteers that work specifically on the wards, and they do lots and lots of different things to support the wards, as I said, to mainly release time back into clinical care, but it's also about that well-being of the staff. So if they can see they're rushed off the bed, think, right, okay, I can go and make a cup of tea, do whatever, and give that person just that 5-minute break and that time out. So yes, there's lots of different things, but that doesn't mean that we're stopping there. We're always open to whatever else they might be able to do to support.
Thank you.
Thanks, Natalie.
Thanks, Rosie. Jackie.
Thank you, Chair. Thank you, Natalie. As has previously been said, it's important, I think, we recognise the contribution made by our volunteers. I think they're quite often overlooked. I was interested in your approach that you mentioned, a volunteer to career offer. I just wondered what that would involve.
Yes, Jackie, so we're it's something that's really close to my heart, and I think we can really give back to the community by offering so many opportunities to come in and experience different workplaces, different staff groups, and that encouragement about different and various opportunities within the NHS and within a hospital. So we're really trying to target those young volunteers who would like to come in and just have some of that experience, a little bit different to work experience, but on those similar veins to be able to open up their opportunities. So we're working hard, and there's a national area of pairs, which is the young people experience in the younger generations, looking at what we can do to support.
Thank you. Thanks very much. Thanks, Jackie. Thanks, Natalie. I think, Catherine referred to Staff Appreciation Week in her report earlier, and I think it's a great time to acknowledge, and I think you use the word celebrate, actually, Natalie, the great work of our volunteers. They make a significant difference to the effectiveness of the hospital and the experience for patients and for staff, as you've just said. And it's great to hear about some of the innovative ways of expanding and the actions being taken. So thank you to our great volunteers from the board. Thank you. Staying with you, Natalie, patient experience.
So again, this is a summary and the full annual report, which does run into pages, but again is a really good read of the innovation and the areas that we're looking to expand and to improve patient experience. Patient feedback is key and is a key driver for us to make improvements and to ensure that our services are delivered to the highest quality that we possibly can, listening to and ensuring that we are meeting the needs of our community. During the last year, it's been the first year of the Listening to and Learning Together framework, which was a piece of work that took place in 2021-2022. I'm looking for Jenny to nod at me, which was a framework that went out to our community, our patients, and actually asked, what do you want to see in our patient experience strategy for us to do moving forward? And our commitment from our staff to actually meet those requirements and develop our own improvement plans so that we are ensuring that we are trying to get it right every time. The most consistent area that when you triangulate all of the data through complaints, through PALs, through our friends and family feedback and comments is with regards to waiting times and communication. And that's the most consistent theme and feedback that we see, and wanting to be kept informed. So there are several opportunities and improvement plans in place from the directorates and across the organisation in how do we do that. So when we're looking at waiting times within the emergency and urgent care department, actually having those boards there and the ability to be able to tell the people who are waiting how long that's going to be. In our outpatient areas, keeping our patients and families involved and informed on the timings and when the appointments are coming up and if there is an overrun. But we're still working to be able to improve upon that. As I said, it is the most common theme that we get from all of our methods of feedback. We've been working with our staff as well to to embrace that feedback, to welcome that feedback and actually ask for that feedback so that we can make improvements. Sometimes that can be difficult to do, or feeling challenged when you receive feedback that isn't necessarily positive, but we're working hard with our staff to be able to actually embrace that and take it forward so that we can go on that improvement area. So we've seen some responses to our feedback. We're particularly in maternity. We've looked at and improved our partnership with our Maternity Voices partnership, and also on Drayton, the feedback was with regards to it was quite noisy and the light level at night. So they've been able to actually action that and reduce the lighting from 10 o'clock onwards, and remind people and remind staff, and the board will know that we heard in part something that really correlated with this morning from a patient story about the noise levels at night, and to remember for our staff, it's just coming to work and it's a normal shift, but actually it's nighttime and we need to be mindful of that. So that's something that within maternity we've looked at, and we know that we're looking at that across the general side. So our listening and learning together framework is relatively new. We are still working towards what we need to do with this, the promises created by our staff and our patients, but also for our patients. And through the Patient Experience Committee and Forum, we're monitoring and reviewing those improvement plans with the directorates and aiding the support where we need to. And all of those, we've changed our reporting mechanism now that we have a quarterly patient experience report that comes through to our Quality Assurance Committee, so that we can keep a real close eye on patient experience feedback and ensure that it is seen as the most important point that we are reviewing and looking at and improving our quality of care.
Thank you very much, Natalie. Questions, comments, observations to Natalie? Thank you, Natalie. Again, a great report. Given the pressures of this year and long waiting lists, I think patient experience is just so important, and it is getting more complicated as it's set out within your covering report. So it's good to see, but also we could say thank you to the patient experience team as well for the great work that they're doing to help us here. So thank you very much. You get a little bit of a break now, Natalie. And I think we've probably got Kirsty with us, Health and Safety and Fire report. There you are.
Afternoon, everybody.
Hi.
Okay, so I'll take it that the paper's read, but I'll just pull out some important points if that's okay. So the report gives an overview of the annual report for health and safety, fire safety and waste management across the trust. So it confirms that we're compliant with all of our policies and all of our statutory requirements, which is good. Our statutory and mandatory training, I'll put my teeth in. Health and safety, we're at 94%, and fire safety at 91%, which again is excellent because it's above the trust requirement. There were 521 incidents reported, which are broken down as follows really. So the verbal and physical abuse one, we had 292 incidents. 96 of these incidents were physical abuse to staff by patients and visitors, and 80 were verbal abuse by visitors and patients. 112 of those incidents were actually verbal abuse staff to staff. There were 49 slips, trips and falls, and dirty needle injuries, there were 49, and they mainly related to sharps not being disposed of correctly or staff injuring themselves during disposal. So for all of those incidents, we put work plans in place, and just as an overview, the needle stick injuries, we're looking at reducing those. Justine Whitmore from a health and wellbeing perspective has looked at those, introduced a new process and undertaken further training with people. So hopefully next year when we report back, those incidents will have reduced. The verbal and physical abuse, one of the issues raised at Health and Safety was actually from emergency care, who raised issues about the number of violent incidents going up in that one area. And as a result of that, the team in urgent and emergency care and our own security team have received enhanced training to help them deal with these incidents in a better way. We had 11 RIDDOR incidents over the 12 months. They were slip, trips and falls, 3 manual handling, and there were 1 which was unspecified. From a fire safety perspective, our enforcement notice for the maternity building was lifted, and we had no other inspections from Warwickshire Fire and Rescue Service. There were, however, 98 unwanted fire alarms, with cooking being the main cause of most of them. I think there were 40 incidents of burnt toast. In terms of waste management, we've generated approximately 100 tonnes more than we did the year before, and I guess that links in with the extra activity on site. 400 tonnes of that is clinical waste that we're disposing of annually. We've also undertaken duty of care audits into all of our contractors, and internal waste audits are also undertaken to ensure we're compliant with the waste regulations. Just to confirm as well, in terms of some of the other things that have come out, fire safety, it was raised about us doing face-to-face and reintroducing it following COVID training. And I'm pleased to say this year we have started doing that, which is a real bonus for our staff because it is site specific. So that's a very brief overview of the whole annual report, and I'm happy to take any questions.
Thanks very much. I have got a couple of questions, but if I can bring in Paul and then Rosie and then Jackie.
Thank you, Chair. Just one, Kirsty, in relation to the physical and verbal abuses. Do you have access to a local security management service who can support you?
Yeah, we have our own local security management officer on site, Karen Moore. She's newly in post in January. She's got excellent links in with the local constabulary and Warwickshire Constabulary as a whole. So, and it's been a real benefit having her expertise on site since January. She's making great inroads. So yes, we do.
That's good to hear. Thank you.
Thanks, Paul. Rosie.
Thanks for the report, Kirsty. I've got 2 questions. The first one is picking up on the staff-to-staff verbal abuse. I'm just wondering, from the data, is that more common in some areas than others? And if yes, have you been able to tackle that?
It's looked at a little bit more in depth once these incidents are obviously reported. I couldn't tell you off the top of my head where the hot spots are, but I'm more than happy to dig that information and provide it to you, Rosie. But yeah, they look at it across the board. There probably are some hot spots, but I'm not sure exactly what they are at the moment.
Thank you. Thanks very much. Oh, sorry, Rosie, you'd got to.
Yeah, and I think Gertie might want to come back to that point because her hand went up straight away. But the second question was, I noticed the increase in waste, and there's a good reason for that. Do you think the level of recycling has gone up in the same trajectory as you would expect?
So we recycle all of our waste, our domestic waste, that is. It goes off to us, our contract Tom White Waste, and they recycle everything. Even some of the items go into forming new surfaces for roads, so they waste nothing. But the clinical waste is different, obviously. For infectious waste, it goes to incineration. So that's the bulk of where the increases come from, I think. So yeah, we recycle everything that we possibly can, but it's done off-site. But clinical waste and other non-offensive waste, we're governed by the Department of Health of how we dispose of it. So none of that would obviously get recycled.
Thanks, Kirsty. I have read a few things recently about equipment being recycled, not clinical waste or bits of equipment. So maybe next time we might hear a little bit more about how equipment or bits of plastic off things can be recycled. But I understand the difficulty with clinical waste that could be infected with products, for example. But I do wonder whether there's more we could do with clinical waste.
Possibly. I think medical equipment we do auction. We send to an auction house and it is recycled. So we do try and recycle as much as we can. And we've obviously got the individual waste streams for electrical equipment, upholstered equipment. So it is broken down. But yeah, it's something from a sustainability perspective we're really keen to progress and reuse as much as we possibly can.
Thanks, Kirsty.
Thank you. Kirsty, I'm going to ask you to come in. I know that it's in the chat, but if I could ask you to just come in relation to Rosie's first question.
Well, as you say, Julia, it's in the chat. So Rosie, anything from a Datex perspective that impacts on staff or has a staff perspective is shared with the people and workforce team, and that then is taken through. And obviously, because people and workforce also meet with and triangulate with staff side colleagues with freedom to speak up, and with the information we have, as we use all of that together to identify hotspots. I'm not sure I'd necessarily say that simply because an area is good at reporting Datex that I would consider them a hotspot. I'd probably consider them an exemplar of good practice rather than a hotspot, because actually we want people to record the Datex. We want them to identify the areas and to, if you will, speak up about it. So as I said, we look at that and we triangulate the data and we work on that. And if need be, then of course we would do work with Sue and Deepa from Speak Up and Civility perspective, or we would do management training, etc. So we do have a response to that. I don't know if that covers everything, Julie or Rosie, but happy to add any more to that.
I think that's an okay, and I think Jackie's put a hand down, which I'm hoping
Yes,
that means that was covered.
My question.
Yeah, okay. Sarah?
Sorry, my question, when you get people started on bins, I'm sorry, Kirsty, but it was just, I know from my own clinical practice that it's very difficult to get people to only put clinical waste in a clinical bin, an assumption that a barely used blue paper bedroll requires incineration. Do we audit? So do we have good training, and do we audit a little bit of what, I know it's not a pleasant job, but what is in our clinical bins? How do we make sure we're not over incinerating a lot of material from the sustainability point of view that really shouldn't be going near an incinerator?
So we do audit on a regular basis. We have an external company that comes in as well that does our sharp spins to make sure that, you know, the correct items are going in them, because they do go straight for incineration. So it's something that our waste officer, Sean's very keen on to make sure you're right, because we don't want to incinerate things if we don't have to. We don't want things, tiger waste, for example, to go into landfill, because it's not very sustainable or green. So yeah, we do audit where we can throughout the year. And infection control do a great section for their corporate induction and their nursing induction as well, training for waste, and us obviously with our domestic services, they have individual training on how to manage waste. So yeah, it's very important to get it right. Okay, hope that answers the question.
Thanks, Sarah. Thanks, Kirsty. I've just got one question. It's about the incidents, because we talked about staff to staff, but there was still a large number of public to members of our staff, far too many that we would want. I just wondered, in terms of investing, how are they reported? They're reported on Datex, and are they then investigated as to the reasons, the causes from what must be frustration around a particular issue?
Yeah, so now we've got Karen in post. As I said, she's been here for since January. She does investigate all of these issues, and obviously some of them are escalated outside of the organisation if that member of staff wishes it to. So yeah, Karen sees all of the Datexes. She does investigate them with the ward manager and whoever else needs to be in place, and they put actions in place as well. So, and there are a lot of them, unfortunately, but yeah, she does investigate them all.
Thank you. Thanks very much for that. Thank you. Thanks, Kirsty. It's nice to see you. We'll move on to subcommittee section for information now. And first of all, Sarah, moving to you around quality committee.
Thanks. I think I don't have anything additional to report there. Quite a lot has been picked up in the reports that have come to board. And I think I'd raised a point to be elevated to board was around that's actually we've already heard has been elevated to the corporate risk register anyway around the cleaning audits. So thank you.
Thank you. And Audit Committee, Simone?
Thank you, Chair. Just two issues to highlight. That one is the validation exercise that's going on around the RTT, just to say that the committee has had assurance that that work is progressing. And then the second point is to note that we had the revised maternity risk management strategy. The committee was able to scrutinise that, and that's now been widened, excuse me, to be the whole of the Women's and Children's Directorate. Other than that, Chair, there's nothing I wanted to add.
Thank you. We'll assume both as read. Any questions for Sarah or Simone? No, thank you very much. Can we take the minutes of Quality Committee from the 22nd of August and the Audit Committee meetings from July to be a true record of the discussion at those meetings? Okay, thank you very much. We're into the closing part of the agenda. Any other business from anybody that anybody would like to raise? No, I haven't either, so thank you. Public questions. Before I open out to anybody in the audience, Sarah, do we have any questions?
We do, Julie. We've had two submitted in advance. The first one is to be brought to the board's attention from John Young at the Patient Forum. John wanted the board to know that when he was volunteering at the hospital earlier this week, the barrier in the main car park was stuck in the down position, and it took him and other people about 30 minutes to get out. This is not the first time this has happened. I know it's been brought to Robin's attention. I don't know if you want to comment at all, Robin.
Yeah, thank you. I'll pick that one up. We're aware of some issues with the car parking barriers and car parking systems that have caused some concerns and difficulties for visitors to the site. At the moment, we're currently working with the company that currently provide that service in order to support with the maintenance and the timely maintenance of the equipment and the barriers to make sure that both the ticket machines and the barriers are working to the best of their ability. But also to note that today the advert has gone out for the expressions of interest to retender the car parking provision on the site, and therefore we would expect by the beginning of the next financial year for that to have all worked through and to have a new provider providing services, and therefore there should be a wholesale change of the hardware and the barriers and the equipment that would go with that. So there is light at the end of the tunnel, but we are doing everything we can in order to maintain services for visitors to the site as best as we can.
Thank you, Robin. Sarah, you said there was a second, and then we'll go to David.
Thank you. So Michael Green has said that with the living wage rising in April, as an ethical employer, can we confirm that all employees at the trust are paid the living wage? And Gert is going to respond to this one. Thank you.
Thank you, Sarah. So I can confirm that the entry point into the NHS, which is the bottom of band 2, as we would call it, is £11.45 per hour. So that is already higher than the minimum living wage that the Conservative government are proposing that we've introduced from April 2024.
Thank you. Thanks very much for that. No other questions, Sarah, already submitted?
No, Julie, that was it. Thank you.
Thank you. David.
Thank you, Chair. Just first of all, a point of clarification, if I may. John Young is a volunteer and League of Friends. He's not a member of the Patient Forum, if I could just clarify that. But the other point, Chair, is that On behalf of all the volunteers at the George Eliot, I'd like to thank those people that put together the annual report on volunteers, and it's great to see that we are seen to be a part of the George Eliot family, and that's how we look at it. The other point I'd like to make, Chair, is it's a pity that the media station that did the report, including the George Eliot and the maternity issue, did not state quite clearly that the information they were working on was from 2021, and that the enormous amount of work that had taken place since that report and statistics to improve beyond any expectations, if you like, the quality of work at the George Eliot. So once again, the media are guilty, in my estimation, of just sensationalising things. Thank you, Chair.
Thank you, David. Thank you for acknowledging the work of the volunteers. They are part of the family, and your view is noted regarding the news item. I think the reporters did say there had been a reduction, but didn't clarify that the data was old or actually the current position. Having caught that
That's
myself.
correct, Chair.
Yeah,
correct.
Absolutely. Thank you. Any other questions from the public? Thank you very much. I'd like to thank all of my board colleagues for the meetings today. We are going into another meeting in a little while. Next meeting will be of the Foundation Group on the 1st of November, and we're back here at George Eliot Board on the 5th of December. So I can't believe that we'll be saying December. It's only October. That's just frightening. So thank you very much. Can I just check, Sarah, if I was to say 10 minutes, would that give time for our visitors to get into our next meeting?
I'm just starting to message.
Okay, so if we can get together back again at 3:45, that would be great. Thank you very much.
Thank you.
Thank you.